So I'll begin this morning with two different case presentations that we've seen at VGH over the past 6 months. The first is a 62-year-old healthy female who presents with an AML, and she's been followed for the last couple of years with serial CTs, and you see that the AML is growing from 4 to 5.5 centimeters on serial imaging. So the questions for you are, first, what are the indications for AML? And secondly, what would be your next step in the management of this patient? So maybe we can just have a poll of the audience to start out. So your options are conservative management with follow-up imaging, angioembolization, or a partial nephrectomy. So maybe if people could just raise their hands if you would proceed with conservative management for this patient. Maybe one or two takers. And who would send this person for angioembolization? A couple more. And then who would consider partial nephrectomy? Okay, some more. So you can see that even in the local audience here that there's some controversy as to how to treat this disease. The second case is another 62-year-old man, healthy, who presents to the emergency department with flank pain and is found to have an 8-centimeter renal cell carcinoma with acute hemorrhage. He's hemodynamically stable, but he does require a transfusion on admission. So the questions for you are, would you consider angioembolization as your initial treatment modality in this patient? So maybe who would send this person for angio after they get to emerge? So no takers. And so given that, I'd just like you to consider then what would be the possible benefits of angioembolization for this man prior to nephrectomy. So with those questions in mind, I'll be reviewing the angioembolization for AML and then review the local experience, how AML has been treated at VGH over the past 10 years with our own data, and then finish with reviewing the angioembolization for renal cell carcinoma. So angio for renal masses and tumors have been around since 1973. It was first described for the treatment of post-biopsy fistulas and then for the palliation of large renal tumors. Developed early application for bleeding tumors in AML, and in the 80s and 90s there was growing interest in angio pre-op to nephrectomy, although that interest and the research in the literature has certainly waned significantly since that time. There are a number of different embolic agents that you can use. For all renal tumors, we use permanent materials to decrease the risk of vessel recanalization. Alcohol works by denaturing the protein of the vascular endothelium, resulting in activation of the coagulation cascade. The coils work through their dacron-wool tails that activate clot formation, and then there are particles, both spherical and non-spherical. And these have become the embolic material of choice in more recent series. There's no study that clearly demonstrates the superiority of one particle over another, or one agent. They seem to have similar success rates, complication rates, and incidences of the post-infarction syndrome. There are new materials, though they're always emerging. The acrylic embospheres are perfectly spherical particles that don't clump together, and so they're able to target vessels, and it decreases the risk of reflux of particles into non-target areas. And then there are the hepaspheres that are said to adapt and deform to the wall of the vessel, and so that decreases your risk of vessel recanalization. When we think about the complications of angio, there are both the general complications, so that would include catheter site puncture complications, contrast-related, anesthetic-related, but then there are complications specific to renal angioembolization. This is a study of 118 patients who underwent pre-op angio prior to definitive nephrectomy for RCC. And you can see that over 50% of these people had symptoms of the post-infarction syndrome, including fever, pain, and nausea. And then fewer patients had other complications like ileus or temporary renal insufficiency.
Steve, are you implying that 40% of MREs is dramatic after tumor kidney lymphomas?
No, this is, so 86% had lumbar pain, but they may have had some of these other, they may have had some other complications, but just not, they just didn't suffer pain. So they may have had fever, but no pain. So The post-embolization syndrome is one of the more significant morbidities of this procedure, and it's generally it's always self-limiting, usually resolves within 3 to 4 days. And the incidence of this syndrome appears to be related to the size of the infarct. There was a study that showed that the narcotic use was proportional to the amount of parenchymal loss. There was another study where they embolized polycystic kidneys, and due to the size of the infarct, 100% of those patients developed the post-embolization syndrome. The treatment is pretty straightforward: observation, treatment of fever and pain. There was one very small, non-controlled study done about 10 years ago that looked at the use of high-dose prophylactic prednisone, and they thought that it was quite successful. No patients developed pain, and only 2 out of 9 developed fever. Although, of course, this is a very small study, it required high doses of prednisone, and there hasn't really been any follow-up interest in the literature. So just about all kinds of renal masses and tumors have been considered for angioembolization, but the most commonly studied have been AML and RCC, so that'll be the focus of today's talk. Unfortunately, there isn't a lot of good quality evidence. The majority of these studies on angio are retrospective or observational. With regard to AML, there aren't any randomized controlled trials to compare angioembolization to other modalities of treatment like surgery. And given that there are no guidelines to really guide the urologist as to whether to treat certain AMLs with angio or with surgery. With regard to pre-op RCC, there are some retrospective comparative studies comparing pre-op angio with surgery to surgery alone, and we'll get into some of the larger ones there. But again, there are no prospective randomized trials to really adequately evaluate this. So I'll begin then by talking specifically about the angioembolization for AML. So AML is diagnosed primarily with CT scan. It's considered the gold standard. Basically, FAT is considered diagnostic, and that's having an area of less than minus 10 Hounsfield's units pre-contrast. And you have to consider the differential for a fatty tumor, but there are other ways to differentiate. For example, RCC. In cases of fatty RCC, all of those cases have presented with calcification, so they're further differentiating features. MRI can also be used, and ultrasound. The picture on the bottom shows the typical appearance of a hyperechogenic lesion with shadowing, although that appearance certainly isn't specific for AML. When you consider the indications for treatment of an AML, it has to be noted that observation is chosen in over 50% of tumors in most series. In the series undergoing angioembolization, bleeding is the most common indication. In cases where there's any suspicion for malignancy, those patients should undergo surgery for a definitive diagnosis. But then there's the more controversial area, and that's which tumor should be treated before they bleed. And tumors over 4 centimeters are thought to have an exponentially increasing risk of hemorrhage, so those are thought to be treated. And then females of childbearing age. And in a pregnant female, the actual risk of spontaneous rupture of an AML is very rare, and almost all of those patients will go on to have an uncomplicated pregnancy. But if it were to rupture, there would be dire consequences like maternal shock and intrauterine fetal death. And so almost everybody would agree that in AML over 4 centimeters, those should be treated. And then if the tumors are less than 4 centimeters, it's still somewhat controversial as to whether they need to be treated or not. Dr. Negro? There was a report of a patient requiring an angioembolization for a bleeding AML. There was one case report, but certainly hasn't the actual incidences of complications of AML in pregnancy hasn't really been looked at. Yeah. I don't think there have been any cases of death or fetal death or anything. So this is just shows a number of different series, and the landmark study that pointed towards the 4 centimeter threshold was the bottom study, Osterling review in 1986. And what they showed is that in tumors over 4 centimeters, 95% of those went on to require some form of surgical or radiological intervention, whereas if they were less than 4 centimeters, only 43% required intervention. And although the incidences are different in follow-up studies, there does appear to be a consistency. The Steiner study just above that showed a 54% risk of requiring intervention over 4 centimeters versus 7% if it was less than 4. So there are a number of different possible modalities of treatment for AML, the most common being angioembolization and partial nephrectomy. So we'll try and compare those in a moment. The indications for total nephrectomy are much more limited, and that would include AML that have basically taken over the kidney, and so there's really little parenchyma left to save. Or in cases where there's diagnostic uncertainty, where there's a high suspicion for malignancy, those are probably reasonable to take for a radical nephrectomy. And then finally, in cases where the tumor may not be amenable to partial, such as high relocation or acute bleeding where you need hemostatic control. Moving down the list, conservative modes of therapy are always a possibility, and there's been some investigation into hormonal treatments because certain AML were found to have estrogen and progesterone receptors on the smooth muscle cells of the AML, and there have been case reports of these AML growing on the oral contraceptive pill or during pregnancy. And then finally, the New England Journal, there is just a recent study that looked at sirolimus in treatment, and what they showed was patients with tuberous sclerosis and AML who were on sirolimus for 12 months showed a 50% reduction in the size of their AML. And if they were on it for 2 years, then the size decreased even further, although the tumors did tend to grow back when the sirolimus was stopped. So that's a new area of interest. When we look at how other centers are managing AML, we see that approximately 50% of the time these are observed. Angioembolization has certainly taken a back seat to surgery, although it seems to be gaining in some popularity. In the SAM study, all 10% of their angio cases have been done within the last 6 years. So given that there aren't any randomized trials to compare angio to other treatment modalities, and there are no guidelines to help us, how do we choose between angio and surgery? And the answer is it's controversial, but it should be based on a number of different patient and tumor factors. So we'll review some of these now. When we think about the efficacy of angioembolization, we have to realize that the goals of treatment are different than surgery. For angioembolization, the goal is to control hemorrhage, to prevent hemorrhage, and to treat symptoms like flank pain, whereas in surgery, your goal is to completely eradicate the tumor so that there's no recurrence and no further risk of bleed. So with that in mind, a review of 14 series on angio showed that the rates of re-angio were 14%, and those were patients that had to be treated again for persistent symptoms or recurrent bleeding. And unfortunately, most of these studies don't have a very long follow-up study, and in that series, the median follow-up was only 23 months. The efficacy also appears to be center-dependent. In one study done over 10 years ago using ethyl alcohol, there was a 19% repeat embolization requirement, whereas a more recent study using particles and coils showed no subsequent hemorrhage at 40 months. This slide's just to show how the AML changes after angio. The CT on the left is the AML prior to angio, and on the bottom it's the AML 6 months post-angio. The graph on the right shows the percent reduction in the size of the AML 6 months after treatment, and the x-axis shows individual cases of AML in one series. And you can see that the average percent reduction was about 50% in these cases. So certainly the AML doesn't just disappear in most cases. When we compare this to partial nephrectomy, obviously surgery wins. These are all a series of partials, and the local recurrence rate was 0 to 3.4% with no recurrent symptoms. It's very difficult to compare the morbidity of angio and surgery, but we can say that surgery requires a longer time in hospital. There's a higher risk of blood loss, and the complications are very different, but the surgical complications have the potential to be more significant. It's usually thought that angioembolization is better able to preserve renal function because of the superselectivity as far as the vessels that you infarct, But in comparative studies looking at treatment for single AML, there's actually both angio and partial nephrectomies have shown no change in the renal function pre and post treatment. And so there isn't for those single tumors, there really isn't evidence that either treatment is any different. This first study by Williams in 2006 showed the GFR going from 95 to 102, and then the partial nephrectomy series, the creatinine went from 1 to 1.1. The tumor characteristics are also likely to influence how you decide to treat these tumors. Tumors over 15 centimeters are likely not going to be as amenable to partial nephrectomy, and if that's the case, then those tumors should probably go angioembolization to prevent subjecting them to total nephrectomy. The location of the tumors can also change things. Peripheral tumors can often be treated well by both surgery and angio, but tumors near the hilum may not be amenable to either. And the issue with partial nephrectomy is obvious, but with angio, the problem is that a lot of those tumors will be fed by a number of different segmental vessels, and it can be difficult to angio all of those vessels, but also you're at higher risk for reflux of embolic materials into non-target areas. And so in those cases, it's probably best to review it with the interventional radiologist to see what the optimal approach would be. No. They can, the interventional radiologists say they can treat just about any size. Yeah, I mean, it'll depend on what the angio shows, but if there's vessels there that they can identify entering the angio, they say they can do it.
Suppose they have very large caliber feeder vessels.
There are. I mean, there are lots of different sizes of coils. I'm not sure what the biggest size of coil there is. I know there was one case in our center where they used coils and then they used pieces of silk. And so they basically fed these pieces of silk into the coil to make it more effective. Patients with tuberous sclerosis are basically a whole separate challenge, not just because of the multifocality of the disease, but also because the nature of their AML are different. The AML are much more likely to grow. In one study of sporadic AML, almost all of them showed no growth over 5 years. Whereas in the same study, the tuberous sclerosis on average grew 4.7 centimeters versus the sporadic that only grew 0.6 centimeters over a period of 3 years. The AML also appear more likely to hemorrhage, 44% versus 14% over a 5-year period. And you also have to consider that there's an increased risk of RCC above baseline. So tumors that do look suspicious, those might be better for surgery. So the considerations for these tumors are basically that you want to have a nephron-sparing approach, but both partial nephrectomy and angio have been performed successfully in these patients, and the management strategy continues to evolve. In cases of acute hemorrhage, angio is usually considered the first line, just because you decrease the risk of nephrectomy and subsequently better chance of renal preservation. It also allows a more rapid patient stabilization. And there are several series that have documented the efficacy of angio in those cases. So I just want to take a couple minutes to look at what the VGH experience has been over the past 10 years. This is some of the preliminary data on a project I'm working on with Dr. So. And how we collected the data was by reviewing the Sunset pathology site for all tumors that were positive for AML. And then we reviewed the Sunset radiology site to find all cases undergoing angioembolization over the past 10 years. All autopsy specimens were excluded, and all cases that had undergone surgery for other reasons, like coexistent malignant tumor or trauma nephrectomy, were also excluded. So this is the summary of our data then. You can see that much more often, surgery was the treatment of choice. The representative population is quite typical for AML, that of a middle-aged female. In tumors that were patients who had multifocal AML or a diagnosis of tuberous sclerosis, those patients were much more likely to be referred for angioembolization as opposed to surgery. And 50% of cases undergoing angioembolization were done so urgently for acute hemorrhage, whereas only 14% of the surgical specimens were done under setting of acute hemorrhage. When we look at just the surgical data, it's interesting that radical nephrectomy was the treatment in more than half of cases. And I think the reason for that is a lot of the patients that were treated for radical nephrectomy were because the diagnosis was still uncertain, or because the AML just wasn't amenable to partial nephrectomy. It was a higher location. The size of the AML was actually not very large. The mean size in the series was 5.8, with a median size of 4 centimeters. And what's interesting is that 4 of these tumors were diagnosed as epithelioid AML, which is considered a malignant type of AML. It's still a new entity being defined, but there's good evidence that this is a subtype of AML that metastasizes to liver and bone. So it's interesting that 10% of these cases were diagnosed with this rare disease. And then finally, 7% of these lesions had evidence of cysts, and that may have contributed to the unclarity of the diagnosis, and that may have prompted them to undergo surgical resection. When we look at the data of angioembolization, we see that 40% of the time particles were chosen, and that was mostly the PVA, polyvinyl alcohol particles. The second choice was the coils in 25%, and then in 20% a mix of materials was used, and that was usually because the initial embolic agent wasn't completely successful in embolization. So conclusions, basically there appears to be a trend towards using more angioembolization, although both angio and surgery are effective treatments. It would be nice to see some controlled trials that actually compare different modalities of treatment for AML in order to better guide us as to how to treat these. And we need longer follow-up studies to really assess the rates of recurrence and retreatment in these patients undergoing angioembolization. So I'm just going to move then to look at angioembolization for RCC briefly. Yeah. Right. Yeah.
It's not uncommon for us to find it for AML. This is that we've already preoperatively, we would be able to use that center with our G-ring.
Right. Unfortunately, we haven't done the actual literature review, so we don't have that data yet as to which were done by which route. And we also need to review the charts to see what the indication was for surgery, whether it was because of a suspicion for malignancy or otherwise. So there are a couple of different scenarios in which you might consider doing angio for RCC. The first is preoperative to definitive nephrectomy. In cases where there's a large IVC thrombus, there's been some suggestion that if you embolize a thrombus, you may make it easier to resect. In cases where there's extensive perihilar lymphadenopathy, by angioembolizing, you can actually ligate the vein before the artery, and that might make your dissection easier. And then in cases where there's a very large tumor, there's been some people that have advocated that there's decreased blood loss and increased ease of dissection if you angioembolize. The second scenario is using this preoperative to partial MIS nephrectomy, and the interesting thing about that is that this allowed urologists to avoid clamping the hilum. So we'll talk about that and their studies in a minute. And then finally, cases of palliation.
I've heard debate on whether it's easier to dissect these maybe needles or less. It's very hard to find people out who want some kind of longitudinal reaction. That's why you get the coil into the lower, and maybe that's a cut right with the coil sticking out the artery itself, and So I don't know, I sort of debate with
Yeah, yeah, and there's certainly debate in the literature as well, and it seems to be certainly there's a lot of mixed expert opinion about that. So again, there's limited evidence available. There aren't any prospective randomized trials to really assess this, and because of that, there's no real consensus on the indications, morbidity, or the outcome benefits of pre-op angio. Many of the large studies were conducted in the 1980s when the initial RAGE was out, and that was prior to the improved techniques that we have today. Most of the reported outcomes in the literature pertain to blood loss, the duration of surgery, and palliation of symptoms, and there isn't a lot of data on the more significant outcomes like cancer control or survival outcomes. So does angio decrease your operative blood loss? The rationale for this is renal artery occlusion should result in the collapse of the parasitic renal veins, and so that should decrease the bleeding response during dissection. There's one study done quite a while ago. This was a retrospective study looking at patients who had undergone pre-op angio and those that had undergone surgery alone. And although the size of the tumors was larger in the pre-op angio group, they did require less average transfusion. And so the authors concluded that it did appear that angio could decrease your blood loss. But there are several other studies that have shown no difference in blood loss, and so this does remain controversial. The rationale for using angio for an IVC thrombus is that 35 to 40% of cases showed a distinct vascularity to those tumors. Fortunately, there isn't a lot of evidence in this area. There is observational data that angio will decrease the size of the tumor thrombus and subsequently may make it easier to resect. Although when this was looked in multivariate analysis, in some of the big tumor studies, there was no change in survival, in overall survival, in patients who had undergone pre-op angio for these thrombus. On the flip side, you also have to consider that there's an increased theoretical risk of sending emboli. And even without angio, the risk of embolus during dissection of a level 1 to 4 thrombus is 3.4% based on a recently published series. And so you have to consider that if you were to embolize these thrombus pre-op, that would probably increase your risk above that percentage. So possibly more importantly is, can pre-op angio improve cancer control? So this is probably the best study that's looked into this, or the largest study anyways. And this was published in 2000 by Zielinski, and it was a retrospective review of patients, but they did show in their data, they suggested that it did improve cancer control. And they had 118 patients who had received pre-op angio, and those were matched to 116 patients who went for surgery alone. And these two groups were matched based on age, sex, stage, size, and grade of the tumor. 95% of these were stage 2 or 3. So in their outcomes, they show that the overall survival, both the 5-year and 10-year, were better in the group that underwent pre-op angio. These are the survival curves showing better survival for the pre-op embolization group over up to 18 years. When you look at just the survival of the T3 tumors, again, you see a better survival, particularly in the earlier years. But of course, this data has to be taken with a grain of salt because it is looking at retrospective data, and there are several other studies that show no survival benefit.
Where was that study?
Sorry?
Where was that study?
It was the University of Southern California, USC. And there are several other studies that have shown no survival benefit when using pre-op embolization. But most of the studies are really not powered to look at survival outcomes. So there was one study that was going to be there was going to be a randomized controls trial looking at pre-op angio and surgery versus surgery alone, but it was never done. So basically, in summary, some of the possible benefits of pre-op angio include increased ease of dissection, decreased blood loss. It may facilitate tumor thrombus resection and improve cancer control, but a lot of this remains controversial because there isn't really great data looking into these outcomes. So if you were to undergo pre-op angio, what would be the optimal time? And it's likely 24 to 48 hours preoperatively, because that's when you would maximize the edema and you'd minimize the period of post-infarction syndrome. And collateral vessels usually tend to form in about 3 days, so you would want to perform the surgery before then. So just to shift gears a little bit, there was one study that looked at angio prior to partial nephrectomy. And this is quite interesting. They had 50 patients with small, solitary, predominantly exophytic tumors, a mean size of 3.5 centimeters. Most of them were in a polar location. An average of 6 hours after embolization, they underwent partial MIS nephrectomy. And in these cases, they did not clamp the hilum of the kidney, and they actually found that this worked quite well. So their outcomes, they had a mean operative time of 90 minutes and an additional 45 minutes to embolize prior to the procedure. There was an average blood loss estimated of 200 cc and an average hospital stay of 6 days. They had a few minor complications. So the advantages of this obviously are that you avoid having a warm ischemic time. The authors also comment that the angioembolization creates a cleavage plane whereby you can see normal parenchyma from embolized necrotic parenchyma, and that might allow your dissection to create a nice plane around the tumor. The obvious disadvantages are that renal cell carcinoma is vasculogenic, so it's really non-selective as to how it recruits vessels. And so in many of these cases, you're not going to be able to embolize all of the arterial feeders. So you can still have arterial bleeding. Secondly, you're going to have venous leak. And thirdly, basically the urologist is dependent on the interventional radiologist to embolize a sufficient border around the tumor so that when you're cutting into the normal parenchyma around the tumor, that you're not going to be at risk for significant bleeding. So there was one follow-up study, I think it was done out of China, that again showed similar outcomes, but this certainly hasn't been taken to the mainstream. And then just a quick word about angio for palliation. A lot of these series are old, but it does appear that angio is effective in controlling hematuria and pain. And there are case reports of successful treatment of paraneoplastic syndromes with angioembolization, including one case report of malignant hypercalcemia being treated successfully. So why is angioembolization rarely performed today? Nobody in the audience would send their patient for preoperative angioembolization. And I think there's a few reasons. First, RCC is detected earlier. So a lot of the tumors that we're treating are, these smaller RCC that are easily amenable to surgery. There's also a lack of prospective and controlled trials looking into this. And even though there is that one retrospective study done out of USC, there's really no studies that confirm that there's a survival benefit. And then finally, there have been advances in surgery and anesthesia, so it's being used less and less for palliation because surgery is often a viable option. That's the end.